I hope that what we've done does become kind of the standard of care and sort of, I think 20 years ago, the idea of urgent cares, wasn't that common.
I don't know who would rather go to the ER than have someone come to me. I didn't know this was an option.
We're able to draw labs, replace IVs, give IV fluids, IV antibiotics, a large number of other medications, pneumonias, complicated urinary tract infections, cellulitis, COPD and CHF exacerbations, and, dehydration, even patients with, slightly abnormal labs, for certain conditions, the types of conditions that we commonly treat in the home, for certain conditions, able to bring to bear a lot of the capabilities, of the emergency department. Like if you were admitted into the hospital versus you were admitted into a hospital at home, it's probably between a half to actually even a third of the cost to the payer.
Welcome to the Unlocking Senior Resources podcast by Leave the Key. I'm Larry Wagner, and I've spent 30 years working with seniors where I was a certified senior advisor, and the last 15 years in the home buying industry as a certified senior transition specialist, where I specialize in dealing with seniors going through a transition in their lives. This podcast is for seniors, those with seniors they love, and people who work in the senior community. In each episode, we bring on a guest who works to improve the lives of seniors. This podcast is your key to unlocking senior resources. Welcome. Today we're here with Kevin Munjal from Care2U. Kevin, thank you for coming.
Thanks for having me.
And just quickly explain what Care2U is, and then we'll discuss how you got to Care2U.
Yeah, absolutely. So Care2U is a high acuity medical practice, and we provide emergency care in the home and hospital level care in the home throughout the lower 8 counties of New York State.
Okay. And we'll obviously dive deep into that. And that is, how did you get to Care2U?
Yeah, so my background is actually as an emergency medicine physician.
Right.
And I have a subspecialty in EMS medicines, like oversight of ambulance systems. And so I spent a large part of my career, in academic medicine. I was at Mount Sinai, got some grant work, some research programs, and then ultimately turned some of these ideas into an operational model that was an early version of what we do now. We were able to kind of reverse the model of, an ambulance bringing patients to the hospital, and instead kind of attempted to figure out a way for the ambulance to actually bring, medical care and the hospital level care into the home. So that was kind of version one. And around 4.5 years ago, I had the opportunity to, help start this program at Care2U.
It's very interesting. You say bring hospital care to the home. I'm looking how much smaller equipment has gotten over the years.
Sure.
The hallways in any hospital are filled with all these carts, which used to be like room-sized piece of equipment. They're now on top of a little, what look like a tool cart to me. And they just roll them into the room. It's amazing what's done. And because of that technology, we're able to bring testing and so on with you. So every call is with an ambulance?
No. So, at Care2U, it's sort of a new model. We primarily have, PAs and nurse practitioners.
Okay.
They arrive in the home. We're typically there within 2 to 4 hours of a request for urgent service. And they bring a lot of capabilities. We're able to draw labs, replace IVs, give IV fluids, IV antibiotics, a large number of other medications. We can do Foley catheters, and we can, change PEG tubes, which is like, stomach tube. We have the ability to get in-home x-rays, in-home ultrasounds. And so we're really able to bring to bear a lot of the capabilities, of the emergency department or of sort of the medical floor of a hospital, short of what's available from a critical care sense, able to bring to bear a lot of those capabilities to the home. And so for the right patients, it can be a really, good solution. Helps avoid, some of the pitfalls of being in the hospital.
There are pitfalls to being in the hospital?
So I take it you're from that comment that you've heard of some of them.
I've heard of some of them, yeah. I've experienced some of them, yeah.
So I'm an ER physician. Yeah. And so, I think particularly I would say for older adults, those with, maybe some dementia and neurocognitive disorders, Perhaps they get, they can, more likely get delirious when they're in the hospital. And so you see these patients waiting for long hours,
Yes.
sometimes in the hallways
Just
in the
gonna say in the
emergency
hallways,
department,
yeah.
right? And they, it's unfortunate sometimes you see them getting confused, and there isn't necessarily always, the staffing available and everything else to kind of, timely get them changed and everything else. Sometimes you see this sort of cascade, of increasing interventions. They get a little confused, maybe they get a little agitated. Now you have to give them chemical sedation, maybe physical restraints. Maybe they now they can't get up and go to the bathroom. Maybe they need a catheter, or maybe you put a diaper on them. They soil themselves, and it just seems to cascade into you came there for one thing, you come out with some other problems.
Yeah.
Maybe you catch an infection. Maybe there's you get a bed sore, and so I think for particularly for those patients, but we see a large number of patients, 18 and over. For those patients, I think it can really provide a better quality of service and experience by caring for them in their home, and they're able to stay with their families, maybe their pets, get the food they like to eat, and if you've got everything set up well for an older adult with some of these conditions, maybe you have home care. Maybe you have, the aids. Once you interrupt all those things and take them to the hospital, it can be hard to get those things set up. So, if it's not immediately life-threatening, perhaps, this provides an alternative for them. We can do the ER workup, get the diagnostic test, figure out what's going on, and then we can even provide hospital-level care, assuming they don't need an ICU or something more serious.
You mentioned that. I'm not sure how relevant this is. But like my mother-in-law right now is in, after a fall, she ended up in the hospital. From the hospital, she's in rehab. But I'm a firm believer she'd get more rehab if she were home. And she had an aide with her before, and now she lost that aide. She has to now get another aide when she gets back home.
Right.
And as you said, we have to restart all over again. It's exactly what we're going to be going through in the next week. We'll find out tomorrow when we'll be going through it, when they have an appointment with a physical therapist. But But you made one comment. This has nothing to do with anything, but you mentioned the PEC tube. My granddaughter has one, and on a couple occasions she pulled it out. She just turned 4, and we went to the hospital. We weren't my wife and I. Both times my wife and I were with her, not her mother, our daughter, and we ended up one time. My daughter was delivering her second child, and we showed up to the same hospital.
Oh wow!
And we said, I hope she doesn't look out the window and see us. This is a very funny story. And we get in, we get out, we're driving away. No, we're in the parking lot. We're leaving the parking lot. The car's on, we're ready to go. And our daughter calls, says, everything okay? See, everything's fine. Why do you ask? Because I just got a bill from a notification from the hospital that you just been released and so on. So we thought we snuck in and snuck out. It didn't work. But anyway, we go to the hospital and they did not have any of the tubes. And luckily we brought our own. My daughter's always prepared and she always leaves one. But that seems like something a hospital should have. And this was Winthrop. It's not a little nothing hospital. It's now whatever it's called now. But I was very disappointed to find that. And both times, if we didn't have our own, they wouldn't have been able to give us one.
Right.
That's crazy. It's a big group. It's a big hospital. But anyway, something that you might have, especially if you know why you're going.
Yeah, so that's an interesting case. We actually we do encourage all of our families with PEG tubes to have a spare in the home, and so when you do have the spare in the home, then we're able to come. We have the staff that can come and change it.
And so I call you. I say my elderly mother, because the granddaughter I could pick up and bring her over. My elderly mother, my 95-year-old mother, her PEG tubes is out. You see, you're going to come there within an hour to 4 hours. You're going to put it in, which takes minutes, and you're done.
Well, and then we also get in-home X-ray to confirm placements.
Yes, okay.
And so we'll coordinate all that. So we'll try to make sure we coordinate all these pieces to get there, and we can usually get there within a couple of hours. A PEG tube coordination might take a little bit more time.
Okay.
But the point is, you get to avoid that very I think uncomfortable, almost traumatic experience of having to be transported to the hospital, often by ambulance.
Correct.
And then sometimes transported back by ambulance. And while you're there, you might be spend a lot of time. We talked about being in the hallway and all the other things. And so, if we can get if you can, we can mobilize those resources and bring them to you. I think it's a great experience.
And a little commercial for you. It took 8 hours. 8 hours.
Right.
So, and that doesn't include the drive time, which is 45 minutes for us either way. The hospital's not so close.
Right.
And so you're talking 9.5 hours to do something that would not have taken 9.5 hours, and it all would have been done in the comfort of the person's home.
Exactly.
I'll call it the patient in your case. It's not a client, it's a patient's home. And that's huge. If we had to spend 9 hours, but our family member's home, that's not to say miserable 9 hours, then driving them there and waiting, as you say, in the hallway with your open gown in the back and all those other wonderful things associated with hospital visits. So that to me is very appealing. Not for my 4-year-old granddaughter so much. She's more mobile. But my 90-year-old mother was not mobile. She was basically in a vegetative state. Mm-hmm. If I had to bring her somewhere, it would have been a Hoyer lift into a wheelchair, somehow getting her in a car. I don't even know how we would have done that. We'd never taken her out of the place. We probably would have had to call an ambulance.
Right.
And that's expensive also.
Sure.
So this seems like a winning situation. So speaking of expensive, natural segue, does insurance cover what you do?
Yeah, so we work with a number of payers.
Mm-hmm.
And so first of all, you can go to our website, care2u.com, and kind of learn more. And if for some reason...
Care2U?
Care2u.
I thought I didn't hear the part.
It's CARE, the number 2, the letter U.com. And you can find out more about some of those pay arrangements. But you can call our number, 833-433-2273, which spells out care for those of us that remember how to dial those letters on the phone.
Oh gosh, is that on your cell phone to have numbers?
They still have the letters. They still have the letters. If you dial that number, our folks will gladly kind of check, make sure that you're fully covered. And if you're not, there might be an out-of-pocket fee on top of your insurance if you don't have a special arrangement with your plan. But honestly, it's probably less than you would spend between the copay for the ER, the ambulance, probably 2 ways on the ambulance, and the amount of time you spend. So overall, it's generally speaking in your favor.
Right. So it's in your favor on I don't want to say medical. I'm not going to say you're getting better medical care, but more comfortable medical care. Is that a fair way of putting it?
Yeah, and for certain situations, maybe it is better, right?
Okay.
I mean, if you have to, when you go to the hospital, if for some reason there's a long delay or you catch another infection, you get a bed sore.
That's true.
All those things. So for certain conditions, that the types of conditions that we commonly treat in the home, pneumonias, complicated urinary tract infections, cellulitis, COPD and CHF exacerbations, and dehydration, even patients with slightly abnormal labs, something called acute kidney injury we routinely do. And then there's sometimes you need to be assessed. Maybe you don't know what your diagnosis is, right? Most of the people listening here are not physicians. When you have a symptom, right, and you need to be checked out, right, whether it be shortness of breath, nausea, vomiting, something vague, dizziness, lightheadedness, these are all things that we can come and assess. And if you're having acute chest pain or you're having signs and symptoms of a stroke, which is very important that all of your listeners are attuned to those are time-sensitive emergencies, and that should go to the hospital.
I was going to ask you that question. My next question. You fall, you hit your head on the floor, you hit your head on the bathtub. You go into the hospital, you're getting a CAT scan, things of that nature. That's nothing you're doing in home.
Yeah, we would recommend absolutely that you go to the hospital. Now, every now and then there might be a family or a situation where you have certain goals of care. Mm-hmm. Perhaps in advance that there's something called the New York State MOLST form, medical orders for life-sustaining treatment. It's a state form, and you could fill it out. And for some patients who are, at a certain point in their life, and their quality of life isn't that great, the families might choose to, beyond being a DNR, do not resuscitate, or DNI, do not intubate, they might choose to be do not hospitalize, DNH.
I never heard that.
Yeah, and so there are some patients for whom they might still want somebody to check them out. Just because they don't go to the hospital doesn't mean they don't want to be, checked out. And so, they recognize that going to the hospital, it brings certain capabilities for interventions, for specialists, surgeries, all those kinds of things, ICU level care. But if that's not like what you necessarily want for your family member, then perhaps You might decide to fill out one of those forms that documents that way, and then you may or may not feel that maybe having Care to You come and provide a significant amount of what the hospital could do, but not sort of those extra layers. It meets your needs.
We had that where I didn't want to do anything to keep my mother alive. I've talked about her many times in the podcast. She had Lewy body dementia. There was no reason to keep her alive. But I didn't want her just being uncomfortable. So something was wrong that was making her uncomfortable that we wanted to treat. But something was life-threatening. We really had no interest in treating that because that would have really been the blessing we were waiting for. So you have to know when to call and when not to call in that case.
Right.
But it's interesting. Do not hospitalize. I never heard of that.
Yeah. And we do have a process, you call us and you're not sure. We have a triage process, and they'll advise you when, there's a red flag and you should go to the emergency department. And then if for some reason there's based on your goals of care, you decide you understand those risks and you still want to go, we have a process, and we'll ultimately, we may agree to come out and see you.
Right. Okay. You're like reading my mind, because that was also my question. Do you sit there and tell the people when it's really more appropriate to go to the hospital? And
Absolutely.
the answer is yes. So you said you were the first employee.
I was.
And the company says 4 years old?
A little more, like 4.5. Yeah.
Okay. And in that time, well, you must have grown because you have multiple, as you said, multiple places from which you dispatch people.
Right.
So where did you start out of those places? I assume one of those locations.
Nearby, the Plainview office is.
Okay.
We had another office right before that, but it's still in Long Island.
Right.
And but we from that one office, we were covering this wide geography, but it made sense to have other locations so that we could be quicker to get to the other areas. So
Sure.
The Long Island City location and the that one up in White Plains helped us cover Westchester.
Oh, very good. And so you said you don't use an ambulance. You go out.
No, so we have our own vehicles,
Right.
Labeled Care to You. You can see them on the road,
Right.
And we have our field staff. In those vehicles, they have all this equipment with them. When they come into the home, they're coming with a couple of different bags of gear. It really is it's quite remarkable. They really are bringing a significant proportion of the hospital right into the home. And, families are often quite amazed. And our folks joke that they have their little Mary Poppins bag. And you reach in there and, quite a bit of interesting things can come out.
That's very interesting. So your role in this?
So I'm the chief medical officer.
Okay. So you don't go see patients, you're helping?
Interestingly, when we first started, we were a small company. I would
Yes.
get out there myself and I would see patients in the home. And
think I'm a better physician for it. As an EMS physician,
emergency medical services specialist. In my career, I have provided care in the home in emergency settings within the 911 system, et cetera.
You're perfect for the role.
Right. So this is an interesting blend, right, of sort of that. It's my emergency care background from the emergency department. It's my EMS experience in terms of overseeing sort of, both a field medical practice,
Right.
and then of course overseeing leveraging telehealth.
Right.
So I initially I would go out in the field as well, but now that we're larger, I think we've had our model has matured, and now we have a lot of really fantastic field clinicians.
I'm going to say
And we have-
maturing. It's probably still evolving.
Right.
Yeah.
And we have a number of great physicians who are typically on telehealth, and it's a concurrent telehealth. So while the field staff are in the home, so they arrive, they do an assessment, they're able to start care, but then they get on video with the attending physician. So on every single visit, you're being seen by an attending physician.
That was my question.
Yeah.
What's the credentials of the person in their home who's coming
So
to see you?
typically a PA or a nurse practitioner.
A PA or a what? Nurse practitioner?
Yeah, a physician assistant or nurse practitioner.
Got it.
typically.
Okay. And then you have a medical doctor, at the other end of the line, if you will. That they're all doctors. Well, the PA is a doctor. Is that correct or no?
The PAs aren't a doctor,
They're not
but
doctor,
but they are trained in line with
Right.
sort of the medical tradition.
Okay,
Yeah, absolutely.
got it.
And they are licensed, independently licensed, and everything.
Right. So you really have full level of care. Because when I go to the hospital, I'm seeing a PA for the most part. The doctor walks in for 2 minutes, looks at the notes, makes a comment, and leaves.
Right. So in this case, you have a clinician spending, 45 minutes, an hour and a half in your home. Plus you've got a physician, attending physician on video spending, somewhere between like, I would say on the shortest, like 10, but up to like 20, 30 minutes even.
You don't get that in the hospital.
Yeah. So you get a really high level of attention, a lot of attention to detail. And because you're in the home, it's very different. So in the hospital, everyone is kind of in a hospital gown.
Yep.
They're in a bed, right? They're in bed too, right?
Yeah, right.
And then a few hours later, there's somebody else in bed too. And, it's a little bit impersonal, right? But when you're in the home, you've got their family pictures on the wall. Each home environment is set up a little differently. And,
it's the temperature they like. It's so cold in the hospital. Physically cold. I don't mean
they've got their favorite blanket,
yes,
right?
Yes.
And the family is around, and so when you're in the hospital, sometimes it's hard for the family to be there, right?
Yeah.
Like sometimes they only allow one person at the bedside. Sometimes
which is too small,
right? And sometimes they can't stay there forever, so there's nobody at the bedside.
Yep.
But when we visit patients in the home, there's assuming their family situation is such, but you almost always have family in the home. Right. So you get to share that conversation. It's always like great when you go to the doctor that you bring, your family or loved one, they can listen in as well, right? You're not feeling well, you can't remember everything they said. So you have your family member there, maybe for an older adult, maybe it's your child, daughter or son. So they're present. And if they're not present, because we're already virtual, and it's like our technology platform is really sophisticated. It's just a few clicks of a button. I'll dial in your family member in Florida,
right? And
they can be there telepresently for the whole visit.
Telepresently,
right? Yeah,
that's a term. I never heard that term. Makes sense.
Yeah, so I think it's really a really nice level here. We make an effort to include the patient's next of kin or their healthcare proxy on every visit.
Mm-hmm.
So, and if we end up like admitting you into our hospital at home and we're seeing you the next day and the next day, you start to get to know our team, and you get an update from the doctor each day. And, in addition to our field staff and our attending physicians, we've got a fantastic team of, care coordinators. And we have a group of nurses that they don't go in the home, but they're helping manage results and communicating, on behalf of the team and handling questions. We have a great group of dispatchers who help, keep operations moving in terms of our field staff, getting everybody to where they need to be, communicating about, when we're going to get there. So it's really remarkable what we've been able to create. And if you think about it, like, if as a physician, if my family member had a medical need, right, they're going to call me first, right?
Yeah, yes.
And then I'm going to think of like, I'm going to do everything I can to figure out how do I not send them to the ER, right? Because it's a traumatic experience. It's everybody's worst day when they go to the ER, right? So maybe I could get labs for them. Can I figure out how to get that in the house? Maybe I can get some fluids, and then I can go over there myself, and I could put an IV in my mom's arm and give her some, like. So we've kind of built all the things that we as doctors probably all kind of want to do for our families.
Right.
So in a way, Care to You is trying to treat everybody like our family.
I got to tell, I'm listening to you, and what's so interesting is I'm 67. I've been a businessman. I own my own business. I'm 22. So did I say I'm 60? I'm 67. I think I said it right. So for 45 years, and I always look at everything like a business, and this is a business, and I'm always looking at profits and loss and just the practical economic component to what you do, and is when you're billing an insurance company, from both sides, the hospital side being at Mount Sinai, a little slouch hospital, no one ever heard of, right, Mount Sinai. So when you're from the Mount Sinai, if I come into Mount Sinai with a certain condition A, whatever that is, or I get treated by you at my home, which is costing the insurance company more, or are they about the same?
So typically, between your insurance company and what's being billed to your insurance company, it's typically a pretty significantly higher cost to get if you were admitted into the hospital
Right.
versus you were admitted into a hospital at home,
Right.
it's probably between a half to actually even a third of the cost to the payer.
Okay.
Now, you as the patient,
Right.
that you may not see that dramatic.
Right. Doesn't change my copay. Well, maybe it
Well,
does.
so when you go to the hospital, your copay. So my copay,
Right.
when I took my son to the ER, I think 2-3 years ago was $300. I think this last year it was $400. And that's a higher amount. Most patients, if we're actually have a relationship with your payer, you're actually just paying like a specialist copay. And
Much less than $300 or $400.
Right? Yeah. I mean, I think mine is like $35 or something like that. And then if for some reason we don't have a relationship with your payer, the amount you're paying is still less than that.
So my mind's reeling from this. I'm thinking businessman more than medical professional. I'm a businessman. I'm not a medical professional. It makes sense. It would seem like this should be the model that should shrink the need for hospitals, because so much of what the hospital does can be done through what you do. If I asked you a percentage, I don't know if you have one, is half the reasons people go to ER something you guys could handle, a quarter, three-quarters? You have no idea. Boy, should you say significant or not significant?
Yeah, so it's a tough question. But what I would say is there's always a need for hospitals. Right?
Absolutely.
And but I think many physicians would agree with the idea that hospitals should really be for true life-threatening emergencies, and for the really complex care, the ICU level care, and all the things they can do in the operating rooms and everything like that. Like that's the part of the hospital that is unique and that needs to be in the hospital. And so if you have one of those conditions, or if you have the symptoms that are concerning for a heart attack, a stroke, somebody's unresponsive, like those are the reasons to call 911 and go to get to the hospital.
Right.
But if you have a fever,
Yes.
Your mother or father is sort of just not acting right, they're not eating as well. Like this could be a lot of things, right? Maybe it's dehydration, maybe it's an infection. There's all these things and we can do a lot of the workup. And if you were to, you might even be thinking, I would go to my primary doctor if can I get an appointment fast enough? You can, fantastic. If you're young and healthy and you can get to an urgent care center, maybe that's the best answer for you. But if you can't get there, then and going to the ER, it doesn't immediately or obviously seem like life-threatening. We can get to you typically within 2 to 4 hours, right? And bring to bear a lot of these assessments and diagnoses. And I'm an ER physician. Most of our docs are either emergency physicians, hospitalists, and have a lot of experience. And so I think we can potentially, take care of you in the home. And maybe we could do it with this initial visit. Maybe you might need additional visits depending on what's going on. Mm-hmm. And you can choose at any point. I believe strongly in patient-centered medicine, family-centered medicine, and something called shared decision-making. So it is our standard that we will, provide you with a recommendation and with some options, right?
I can't imagine, except by hospital administrators, who would argue that people would prefer this level of care, this type of care. I don't say level, this type of care, the care at home. I don't know why anybody would not want that instead of going to an impersonal, ER. And again, you're a 2 to 4 hour timeline to get there. So let me ask you one question on this, and then I'll continue with my train of thought. When I call you and I say my mom she's kind of delirious and blank, you say, okay, we'll check her out. Do you tell them it's going to be 2 hours to 4 hours? You say I should be there in 2 hours. I should be there in 4 hours. Do you know at that point?
We'll typically give you a window for when we can arrive.
Okay. I assume much of that's just travel time.
Sure.
So that you should have a good handle on. Well, we live in New York.
Yeah.
A New York good handle. But it seems like I don't know who would rather go to the ER than have someone come to me. I didn't know this was an option.
Yeah. And that's the biggest takeaway I hope from this interview is that there is an option.
Okay.
Right?
So I'll answer my biggest takeaway question later. Yes, there is no. I'm going to ask you a question you may not want to answer. Do other people do this? And if they do, not as well as you, of course, but do other people do this? Are there other companies, I should say?
I don't think there's anyone that does it quite like we do.
Okay.
I mean, I think there are services you can get, like, if you want to get sort of IV fluids after
Yes.
you had too much to drink or something like
Got
that.
it.
There are those kinds of services. I think there are some that do kind of a lower acuity kind of urgent care, but in terms of we really focus on high acuity, high complexity medical care. For patients, our goal is to really help change the setting. Our goal is to help patients and, perhaps help their doctors and health systems by changing the setting of care, right? For things that we can potentially do in the home, let's move some of that care, from the ERs and inpatient to the home setting.
Hi, I'm Larry.
And I'm Ben. We're the father and son team of Leave the Key Home Buyers, and we want to buy your house.
We specialize in working with seniors who are transitioning out of their homes, and we understand what you were going through.
So if you're considering selling your home and would like an alternative to the traditional overwhelming process, reach out and see how we can help.
Do you have an outdated home?
No need to update anything.
Have a home that needs repairs?
Don't bother with repairs.
Don't want to take everything with you?
Leave whatever you want behind.
Dreading the headaches that come with agents?
Sell your home without paying a commission.
Dreading prying neighbors attending open houses and passing judgment on your home?
No need for public showings.
When you sell to us, you'll have all the certainty of closing on your timeline, not someone else's, and there's absolutely no pressure.
Visit leavethekey.com or call us today for a no-obligation offer at 631-388-7771 if you want to sell your home today.
That's better for patients, and it's better for payers. And if it's better for payers, hopefully it comes back to us all in terms of our insurance premiums.
That's right. Oh, yeah, right. Yeah, it's like gas prices go down, right? Well, when they open the Strait of Hormuz, we'll see. Anyway, Chris, we didn't even get gas oil from there, but yet our gas prices went up. But that's another oil, I should say. But that's another story. But also someone else you didn't mention that benefits, and that is the people in the waiting room at the hospitals. They benefit too with fewer people going to hospitals for things that can be treated by you.
Absolutely. I mean, as an ER doctor, you constantly have to do your best to triage and sort of take care of those that are sickest first. And but it's not always that apparent,
Right.
And so either way, I think the patients that need to be there, need to be there. And if we're able to move some of the other situations to the home, that's great. And it's not just us. If they can be seen at urgent care, be seen by the primary doctor, or be seen by telemedicine, that's fantastic. And I think we fit we provide a really I think high value proposition, because it's not just telemedicine. We're actually physically in your home.
Yes.
We can touch you. We can take your vital signs. We can draw labs. We can we come with a lot of gear and capabilities. So it really changes the dynamic, so that you are getting, as opposed to, I think, other services that you mentioned, like that focus on lower acuity care or focus on our telehealth only. They're still going to escalate a significant number of those patients to the hospital. Whereas much less so. Yeah.
So I'm going to run a scenario by you that we've experienced. So family member goes to the hospital. You're in the waiting room. First, you go to the waiting room. Then they check you in. You have to go back. I'm bringing someone who's in a wheelchair. So I had to get him to the hospital, which is a pain in the neck. It wasn't worthy of an ambulance call, but severe pain getting in out of the car and so on and so forth. And get him to the hospital. The next time we just wheeled him to the hospital. It was close enough. Literally took him in a wheelchair from his apartment to the hospital. But it's uphill like 2 degrees. It's really hard pushing a wheelchair up even that little hill. But anyway, I didn't realize there was a hill because I'm always driving up the hill. You don't think about it. But putting that aside, so we now get him to the hospital, get him in the waiting room. They then call him back. They have to go into this room, wheel him into the room, take off his jacket, because he has to but he's in pain, so taking off his jacket hurts. They then do some vitals on him, ask him a million questions, go back to the waiting room. An hour later, they call him in, put him in the hallway, or they put him in on his gurney. They put him on a gurney in his big room, right, with all the gurneys lined up, and your privacy is that curtain, because that gives you privacy. And then you wait for someone to show up, and someone shows up. You don't know who it is. They're there in the back in 2 seconds. And then every now and then someone shows up. You try to ask a question. There's not a lot of communication. And then maybe you'll get an answer from somebody as to what they're actually looking at and so on. And the doctor pokes his head in. The doctor takes his head right out. It's like the hokey pokey, So, and then just my family member looks at me and says, so what's wrong with me? And I said, I don't know. 5 people just were in here in the last 3 hours, and I have no idea what's wrong with you. And so he's there for 3 hours or 4 hours, if 5 hours include waiting time, and he probably has 10 minutes worth of medical professional time in those hours. So in your case, you're condensing the amount of time you're spending with me because there's no downtime in between. You're not running to another patient. And I'm with you every minute. You're with me. I'll rephrase that. Every minute. Let alone I haven't had the travel time and I'm in the comfort of my home. But it's more with the amount of downtime in an emergency room is outrageous. Now, sometimes you wait for results. And I remember they did it in the same business. They did a test. Now, how long before you get the test? It depends when the radiologist reads it. So, and it was literally hours and hours and hours. And the radiologist read it. But they have to wait for the doctor to find time to come and talk to us, say what the radiologist read. It was like 6 hours for something that probably took 10 minutes. So now I'm not getting stuff done in my home with you that's going to a radiologist, I'm assuming. Is that the case?
So we can arrange, for particularly for homebound patients, but we can arrange in-home x-rays, in-home ultrasounds, even in-home echocardiograms. And, we can...
echoes, that's interesting.
Yeah. So, and then you do have to wait for the results, but at least you're waiting at home.
You're waiting at home. Yeah. It's so much better than a cold room with my gown,
And then we'll have somebody from our clinical team give you a call with the results. Obviously, if it's critical, we'll call you right away. And if it's not, we'll call you.
I don't mind waiting if I'm home watching Bonanza, whatever. That's okay. Anyway, it's to me, it's a no-brainer. So you say, it's not going to cost me more. It may actually cost me less. I don't have to travel. I'm going to be with my healthcare provider the entire time. Well, rephrase that, my healthcare provider's with me the entire time. So the question I have is, so you're kind of early to the game with the level of care you're giving. It seems inevitable that other people are going to do this, that the insurance company is going to push for this kind of care if it's costing them less money. And the insurance companies control medicine more than we want to admit.
So we've got some great partnerships with insurance companies. I think a number of payers are either paying for this or expressed a lot of interest in paying for this service. But even if we don't have a relationship with your payer today, we're still able to provide you that care. Again, there might be an out-of-pocket cost above the insurance, but
it's still less than the emergency room.
It's generally less than the emergency room. Obviously everyone's situation is different. So, but you can call and again 833-433-2273 or careu.com. And you can find out for yourself. Right. And it's better to actually do the research ahead of time.
Right.
So if you're listening to this podcast, go over to that website, research it. You can give us a call. You can even sort of set up a little registration or a little, sometimes we'll do a quick telehealth welcome visit where we'll kind of just explain the services to you. But if that way you have it ready when you need it, right? Yeah. And then so it's a little less stress. In the moment you have a symptom, rather than waiting till the last minute trying to, and then, searching and maybe you find us, maybe you don't. This way you have everything prepared ahead of time. So I'd encourage all of your listeners to, consider that. And then, I think as you said, I think the value is tremendous, whether, for you, your loved one, I know you have listeners who might be sort of in the industry taking care of older adults.
Yes.
And I think for them to, potentially recommend us to their clients, they'll be grateful to you to have helped them avoid, going to the emergency department.
I want to talk to you about something after the podcast that may be of interest to you, a show that will attract the right potential patients of yours. Sometimes things just seem like a no-brainer, and not that often. That, there's usually some downside. I'm really not seeing a downside. the one, so if I'm going to go see you and you said, oh, you really should be in the hospital, but the reality is you've already told me that in advance. If you think it's something you shouldn't be handling at all.
I mean,
doesn't mean it never happens.
no. So I just to clarify, right?
Yeah.
So like, there's going to be certain red flags at
Yes.
triage, but then there's going to be other situations when we arrive in the home, we do an assessment. Now you've got the actual, you got the field clinician, you've got the attending physician.
Right.
So now you have a lot more information. So it's possible that, we then say, you know what, I really think that you'd be better off in the hospital. And very importantly, I firmly believe that like, you and your family need to be the ultimate drivers of decision making.
Yeah.
When you're in the hospital, you're kind of on the hospital's turf.
Yeah.
Like how often is it that like, the doctor, orders a test, a transport technician comes to the room and the patient says like, oh, like what do you mean? Like what test am I getting? Why? And so, it's a very different experience at Care to You because we're going to be communicating with you. We're going to be explaining to you what we would like to do, what we're ordering, why we're ordering it. And then we're kind of on your turf. We're kind of a guest in your home.
Yeah.
Right.
I like that.
And so we're going to advise you. I really believe that physicians and clinical folks, we're here to advise you. At the end of the day, it's you and your family that are making the decision, right? So we'll present you with the options. And there's going to be times when I recommend to you to go to the hospital and I'll ask you, is that how do you feel about that? Is that consistent with your, what your goals are? And if for some reason, as clinicians, as physicians, we think that, like everything's the textbook, right? I don't mean that we say that, but the textbook tells us you have this condition, you need X test, right? It's the next step. But that doesn't necessarily mean that that's the right decision for that patient in that moment, right? Mm-hmm. And so what we try to do is explain to them, listen, based on this condition, I recommend this test. But if that test is getting a CAT scan and you're in the home, that means going to the ER now,
right? Or
maybe that means arranging that as an outpatient. And by the way, we can arrange outpatient CAT scans and all those things. But if it's time sensitive, then maybe the best place is going to be the ER. So yes, of course, we do escalate patients to the hospital, but we'll do so kind of in alignment with the patient's goals and their, if what's most important to them is making sure that we're going to do a full workup and assess and find things and treat things and they want the interventions. Mm-hmm. And the safest place is probably going to be the hospital for those, especially where we're about time-sensitive condition. But I would say that there are a lot of patients out there, particularly older adults, neurocognitive disorders and other things in which they or their family, that's not the most important thing.
Right.
The most important thing is to be cared for from and be in their homes and be comfortable. And I think for those patients, we'll still explain to them, okay, here are the risks, here are the benefits of both options, and give them the power to actually help derive some of their care. And we've had remarkable feedback. I mean, our patient satisfaction scores are really through the roof. Mm-hmm. There's something called a net promoter score, and we're like over 80, which in healthcare, I think anything over 30 is considered impressive. And
the 8 doesn't sound so great. Up to 8 out of 100.
Well, it's actually 100 to negative 100.
There you go. That makes it much better. Okay.
So, and if you get an 8 out of 10 on these things, it's actually driving you down. By the way. So
really?
You really have to get like 9s and 10s, and we are like 80 plus, almost often like 90 plus net promoter scores. And why is it? It's because we it's not only that we brought the care to the home,
right,
but we also bring with it something I call the Care to You promise. We bring sort of a focus on patients, their families.
I was going to use the word attention.
Yeah, attention.
Yeah.
And we follow through. Like we make sure you get your results. We send a prescription. We make sure you actually receive your prescription, and we make a referral. Try to make sure you actually got the referral, or we refer you to home care. Make sure that home care came in, actually started. So that follow through and that commitment to excellence is, I think, what really separates Care to You.
Yeah, it's so funny how I talk about how Sears and Roebuck started like the catalog business, and we moved to big retail stores, and now we buy online. Like it's going back. The old days, doctors went to you, then we developed you go to the doctor, and then even the clinics and everything had the walk-ins, and now you're bringing care back to home, which to me seems like an absolute. The numbers work for you. You can afford to do this for less money, even with the travel time, because you don't have the massive investment and overhead a hospital has to do the very same things you do. And you don't do everything they do, but they do what you do. So I want to make sure it's a one-way street. But their overhead is ginormous. I mean, beyond the realm of comprehension if anyone is not in the field and the financial end of that business. You don't have that. So you have staff, some cars, some equipment. I mean, it's a whole different animal. So you can really bring affordable health care to the people instead of people going to the unaffordable health care. I mean, come on. I'm holding my hands like a scale imbalance for those who are listening. It's just a no-brainer. I keep saying that. I'm dumbfounded. This is not like all over the place.
Yeah,
That's what blows my mind.
Again, we're really proud of the service we built and what we deliver, and it is, I think we provide tremendous value.
Yeah.
And we're fortunate to those payer partners that have seen that value and are helping make it affordable for us to do so and for the patients. And then, there's a number of other payers that we're still talking to, and I'm very hopeful that they'll come on board.
I would like to think they would for their own benefit, if not for other reasons. But give me an example of someone you treated recently that I would never think of calling someone, a doctor, if you will, to come see me in my home, like Dr. Schwartz used to see me when I was a kid in the 60s,
Sure. So, we have a number of patients. I'll tell you about, one patient in particular. She was, I think 100 years old, still with it, still able to communicate. And the family noticed her being a little bit more confused, a little bit, lethargic, not eating so much. They called, their primary doctor. I don't think they got through the primary doctor, but the office said, I think you should take them to the hospital. And so they called us. So we arrived, within a few hours. We assessed the patient. She's a little bit, her blood pressure was a little bit on the lower side. Heart rate was a little bit fast, had a fever. We did lab work. We had to, she couldn't give us a urine sample, so we actually are able to do a straight cath. So get a clean sample. We do a dipstick right there in the home. It comes out positive, and we're able to, start antibiotics. She was kind of, more lethargic, not at that moment, couldn't necessarily take pills.
Yep.
Right? So we actually have IV antibiotics. So we started them on an IV antibiotic, gave her some fluids. We admitted her into our hospital at home program. We have some remote patient monitoring equipment. We can, with the family's assistance, we can check vital signs, even when we're not there. And then over the next, 24 to 48 hours, she, kind of bounced back. And then, we review the labs each day. We saw that she had some electrolyte disturbances. We worked on adjusting those. And then we were able to, we don't call it discharge. We transition them,
right,
to our post-acute period in which we continue to follow them. We still make phone calls after the we're no longer doing the in-person visits. We'll continue to call them usually daily for a couple of days, make sure they're doing okay, got all their meds. We switch them to oral antibiotics. Did you get to pick them up? Did you take them? Fantastic. How are the vital signs? How are you doing? And then if anything kind of raises a red flag, we'll come back in and see them again.
Who's making those follow-up calls? Is it a nurse?
We have a care coordinator team as well as nurses, yeah.
Okay. That's a perfect example because we went there with my mother with a urinary tract infection and we thought she was developing dementia. And they did all those sorts of tests and then we read that's a very common cause. But did all these tests. That wasn't the first thing they went to. But all right, is what it is. But she was in the hospital for 3 days over this. And over something that this woman never had to leave her home.
Correct.
So that's a perfect, really close to home example for me because, and again, as one of the caretakers for my mother, actually, one of the caretakers for my mother, I'll leave it at that, my wife and I, it would be so much easier and make for a less ornery patient.
Right.
That's for sure. So, this is I'm just dumbfounded that this is only 4.5 years old, that this hasn't been being done. I guess technology is making this more doable than ever before.
I mean, I think people are more comfortable with telehealth. I think people are more comfortable with the idea of care in the home. I think we're able to we have our field staff. They have iPads.
Yep.
And we have the EKG machines that attach to the iPad.
Uh-huh.
And we've got there's ways to administer medications. It's most of the traditional stuff, but you're able to as an EMS physician, a lot of this stuff we're already carrying in a 911 ambulance. We carry a lot of this stuff, so it's a little bit of adjustment in terms of the exact details of what we carry. We're able to really focus more on delivering that sort of hospital at home type of care model.
Right. Are these are the employees going to the homes in their cars, or you have outfitted cars?
Outfitted cars. Yeah.
Okay.
Yeah.
I've never been speechless.
Yeah.
I mean, probably my whole life, but I'm kind of speechless on this one. This is you laid it out perfectly. Exactly what you do, the benefits, the cost benefit,
and one thing that's really I think that's really unique is even something like shortness of breath. Now, of course, a shortness of breath there's a spectrum, but if the shortness of breath is developing slowly, the person's still able to speak in full sentence, but it's subjective, and maybe they've got a chronic condition like congestive heart failure or COPD. They're able to, we're able to arrive, assess them. We actually carry oxygen concentrators with us, right? So their oxygen's a little bit borderline. Patients that have like a respiratory infection, like COVID or something like that, the biggest thing we worry about is if their oxygen's going to go down. And so by being able to deploy oxygen concentrators right there in the home, and then if it's appropriate, we'll order through a DME company and make sure that they have what they need for long term. But for the short term, that acute phase, there really isn't, a great service out there that can do all of the things that we can do. I think there's some great primary care doctors that provide amazing care and responsiveness to their patients. But the truth is, I think there's, there needs to be some reform to the model to make sure that primary doctors are being valued for their services. But when the primary doctor is trying to figure out a way to serve their patients, and they look around and they might know what they think the patient has just over the phone,
right?
But is it really
feasible to handle it? Pre-care you. Was there really a great option?
Besides saying, I think you have to go to the ER because that's the fastest place to get, be seen, right? That's the fastest place where you can get a test done or this and that. And again, if it's not immediately time sensitive, we can't do quite as fast as the ER can do, but the wait time is, here in your home, right? So we can get to the home, we can make sure they get the appropriate diagnostic test, blood work, in-home imaging if they're homebound. I think for a primary care doctor trying to help their patients, age independently or age safely at home, this is a really great option. And sometimes you just don't know, right? Can I manage this myself? Can I just have them come to my office tomorrow?
Yeah.
Can I wait till tomorrow? I'm not sure. Versus, the only other option is the ER. Those options are just extreme.
Yeah. Yes. They're very extreme.
And so this creates a middle option.
Yeah.
And I would. You asked me before what percentage of cases I would guesstimate that a third of the phone calls that a primary care doctor office gets that they end up referring to the emergency department.
Right.
Probably could be handled by us, maybe more. I hope that I hope that what we've done does become kind of the standard of care and sort of I think 20 years ago the idea of urgent cares wasn't that common and so
that's because you could call and get, I'm sick, I want to see you. Okay, I have an appointment available at 2:00 today. Okay, you don't get that anymore. they can't seem to fit you in if you're sick. They only see you when you're well.
It's harder. I think the system's overwhelmed, but the urgent cares they're like this new category,
Yes.
right? And I hope that in a few years' time, that this
You'll be
this
that new
category of care that we've created, I think, becomes common knowledge, and of course you would call care to you. I hope we become the Kleenex of this
Right.
category, right?
Right.
Like, of course, get care to you to bring that care to you.
But you're right about urgent care. It's a new paradigm. It's a new concept. I mean, relative in the scope of medicine, and you seem to be a better version of that in that I don't have to go there. They come to me. Now, when you go to, well, the one I go to, it's funny, if I want antibiotics, I go to one. If I don't want antibiotics, I go to a different one. Because they never prescribe antibiotics. The other one always does.
Interesting.
So I become my own doctor to decide. I mean, which is kind of crazy. But that's what, and everybody knows. Antibiotics, no antibiotics. We live right between two of them. So go east, go west. But I like, this is so much better. But I got to tell you where I go, on the one with the antibiotics, you don't wait. The one with no antibiotics, you wait longer. It's just, I guess people don't want antibiotics, so they go to that one. But I have a question for you on that. Because when I go to the walk-in places, there's usually just 2 or 3 doctors in the practice. So I'm seeing, if I'm going in there multiple times, I'm probably going to see the same doctor. With you, if I live in my home here in Huntington and I call, what are the chances I'm getting the same doctor for 6 months later? Assuming your staff hasn't turned over or whatever. Do you have like do your people stay in one small area, or does it work that way?
I would say it's probably not that dissimilar from an urgent care. I mean, there's a rotation, of course, but
Yes,
I think there's and we're growing, so there's always going to be more staff. But I think that at the end of the day, I think we do. We're really careful to make sure that the information is well documented. That, our notes are really thorough, and by the way, we send our notes to your primary care physician.
Okay.
Right. So when they go to the hospital, not all the time does the primary care physician get as good communication as they do from our practice. So
that's interesting.
That's really important. A piece of connective tissue, I think.
Connective tissue, spoken like a doctor.
Yeah.
Is there anything I missed in asking questions? I want to ask, besides my big takeaway question, which we'll get to, which you already answered, any things that you want to say that I didn't address?
Well, I think we've addressed most of it. I would just say, it's been kind of a privilege and an honor to kind of build this model of care from the ground up. And I think that there's, I have a world of respect for so many that have, helped to mentor me over the years. And, I hope that, all the little mini battles we've had to to push through to kind of create this model that there's that at the end of the day we're able to make this survive and thrive and grow, we're hoping to certainly expand care use footprint to perhaps further north in New York State and New Jersey, Connecticut, and other areas, I know that throughout the country there are little, models of care kind of popping up that, might have some overlap with what we do. But either way, I think this category of care has this tremendous potential, and I hope it really does grow.
Yep, absolutely. Absolutely. Well said. And I appreciate your sentiment about those before you who mentored you. So the big takeaway is that people should know about this, that they don't know this exists, and now they know it exists, and to take advantage when appropriate.
Absolutely.
Yeah.
I want people to know that there's an option when it's appropriate, right? When it's not something that you think is life-threatening, and we're able to bring a significant portion of what the emergency department and the hospital are able to do to the home in a timely fashion, and I think that. Again, beyond just doing it in your home, I think we try to really bring a quality experience, evidence-based medicine, but in a patient-centered, family-centered way, really value shared decision-making. And so to do all that, it's, there's a huge team at Care to You. So for anyone listening, I want to thank everyone on our team, all of our field staff, all of our nurses, all of our coordinators, our dispatchers, and everybody else. And it's been an amazing journey so far, and I hope the best is yet to come.
Yep, I anticipate it will. I mean, it seems like a phenomenal idea, and the depth and breadth of what you can accomplish in the home is phenomenal. So you've mentioned before, but repeat it again. So it's care to the number 2 U, the letter U, .com.
Correct.
And now they're not going to reach Kevin, but they're going to reach care to you.
Yeah, they'll reach.
And how do they reach care to you?
So care2u.com, and our phone number is 833-433-2273, or care, the last 4 letters on your phone. And you'll reach a member of our team. You can register. You can even before you have a emergency, you can get sort of set up in our system as a new patient, and perhaps you want to schedule a welcome telehealth visit. And otherwise, if you or a loved one has a condition for which you are considering going to the emergency department, but are trying to find an alternative, I think we provide a valuable alternative.
I do too.
If you signs and symptoms of a stroke, signs and symptoms of a heart attack, unresponsive, those are things you have to call 911 for and go to the hospital.
Yep, that makes sense. You are what you are, and you're not what you're not.
Absolutely.
Kevin, thank you so much. I really appreciate you coming.
Absolutely. Thanks so much. Thanks so much for having me.
You're very welcome. Thanks for listening to this episode of the Unlocking Senior Resources podcast by Leave the Key. If you've enjoyed this episode or found it helpful, don't forget to subscribe, leave a review, and share this podcast. We specialize in working with seniors who are transitioning out of their homes, and we understand what you are going through. So if you are considering selling your home and would like an alternative to the traditional overwhelming process, reach out to see how we can help. When working with us, you can sell your home in its current condition, there is no need to remove unwanted items, and you control when the house is sold, along with so many other advantages. Visit leavethekey.com or call us at 631-388-7771 to learn more about our senior home buying process.